The nursing process is the method nurses use to plan and deliver nursing care. So whenever you have new admissions, when the person comes there to live, the nursing process is initiated. The first thing is the assessment, then the nursing diagnosis, planning, implementation, and evaluation. If done in good order with good communication, nursing care is organized and has purpose. All nursing team members do the same things for the person. So they use the nursing process to create the care plan, and everyone follows that care plan. All nursing team members have the same goals, and the person feels safe and secure with consistent care. So not only do they have consistent care, in long-term care centers, they usually have consistent staff as well. And these little old folks don't like change. They like consistency. And so that's a good thing. All right, so now we'll begin the steps. First, assessment. Collecting information about the person. Typically, when that new admission comes in, the nursing assistant is going to be the first one to meet them. And you will initiate the nursing assessment. Get their vital signs, listen to them. Do they talk clearly when they speak? Do they speak intelligently? Do they know what they're saying? How well do they hear? How well do they enunciate words? Do they know where they are? You always will make observations about people when you give care and talk to the person. You will be tested and need to know the difference between objective data and subjective data. That's on page 67. Objective data is also called signs. Objective data, things you can see, measure, feel, smell, or touch. Subjective data, also called symptoms, are things the subject tells you, things you can't see or measure. I feel dizzy. I feel nauseous. My back itches. So there's a difference between subjective and objective. The assessment step never ends. New information is collected with every resident contact. So every patient you have is going to change. They're either going to get better or worse. So if you were being admitted after you've been in the hospital, you fell and broke your hip. You fell because you have Parkinson's disease and you have a tremor and you're a little unsteady on your feet. So now you're being admitted for therapy for your hip. So I would approach her. Good morning, you must be Miss Taylor. Could you tell me your birthday, please? And I'm going to check her record to make sure the birthday matches. So Miss Taylor, how are you feeling? And she would tell me how she's feeling. And I'm going to look at her and listen to her. How does she speak? Does she speak intelligently? Does what she say match what I'm asking her? And then I'm going to ask her, when I put up my hand to shake her hand, when I introduce her, what does her skin feel like? Is she sweaty? Is she cold? Is she trembling? Is she afraid? Is that a somatic tremor? Is there something diagnostically wrong with her? That's very important that you do as well. Look at her face. Are her eyes clear? Does she have any drainage around her nose? Are her lips chapped and dry? Does she seem like she's dehydrated? Her nutritional status, does she look healthy? And you do. So I'm just going to assess everything about her that I can while I'm interviewing her. I'll get her vital signs. That is objective because it can be measured. And subjective, what she tells me. Even if it's something as crazy as, I need to pee. I can't feel that. You have to tell me. So that's subjective. But every time you interact with a patient, you're going to find these things. And it could be something very trivial. You might go in the room to visit them today, and they're not as happy as they usually are. And you think, oh, no big deal. She probably doesn't sleep good. Ask them. What's wrong? You don't seem your usual self today. My dog I had for 10 years has been living with my daughter, and he died. That may be nothing to anybody but that person, but you're their advocate and you're their friend. Talk to them. See if you can't get that daughter to bring some pictures of that little dog so they can keep them in their room. Things matter, and it doesn't have to be a physical issue. But again, you will make assessments every time you interact with a patient. All right, so once the information is collected, the nursing assistant gets information, and then the nurse goes in and does more thorough assessment, like listen to lung sounds, listen to their heart. The nurse will listen for abdominal sounds, check pulses, all those more deeper assessment signs and symptoms that the nurse can observe. Okay, OBRA MDS requirement. OBRA requires a minimum data set for nursing center residents. This is a screening tool and an assessment tool. So all the information you get about this patient goes into this paper. There's an MDS nurse in every facility that does these assessments. When they're complete, they're sent off to Frankfurt or wherever Medicare and Medicaid offices are for reimbursement. So not only does it tell the facility and statistics what kind of patients you're receiving, but it also gets reimbursement from Medicare and Medicaid. The MDS is completed when they're admitted to the center. It includes their diagnosis, all of the issues they need help with. Do they need help with a bath? Do they have to be fed? What is their diagnosis? How much of this has to be assessed every day? The MDS is updated for each care conference because it's included in that care plan meeting. These are the problems we're addressing for this person. It's also done once a year and whenever there's a change in their status. The MDS is signed by the nurse to show it is complete and accurate.
Is there a role for the nurse aide with the MDS?
Yes, it's very important when you document your activities of daily living that you document how much help they needed, and it has to be accurate because the MDS nurse is going to take that information to add to the assessment. And that again goes back to reimbursement. The facilities are reimbursed for how much help has to be provided for that person. Okay, so we did the assessment, and now we're going to create the nursing diagnosis. The nurse uses the assessment information to make nursing diagnosis. There is a difference between nursing diagnosis and medical diagnosis. A nursing diagnosis describes health problems that can be treated by the nursing department. A medical diagnosis is identification of a disease or condition by a doctor. So the person can have multiple nursing diagnoses. On pages 72, 73, and 74 are a list of North American Nursing Diagnosis Association's nursing diagnoses that can be utilized. So there's a lot of them. For example, at risk for falls. What can we do about that? We can make sure that they wear non-skid shoes. They have their cane handy. They have their call light handy to ask for assistance. So these are things that can be treated with nursing measures. Okay, so the nursing diagnosis. It involves a person's physical, emotional, social, and spiritual needs. These diagnoses can change or new ones can be added as this assessment information changes. So when they get new problems, we add them. When problems are resolved, we can take them off.
So let's say that Taylor does have Parkinson's disease and a tremor.
Mm-hmm.
What type of diagnoses would she get?
We could treat her for at risk for falls, first of all. We can treat her for assistance with eating. We can treat her for assistance to the bathroom. So there's a lot of things that the nursing department can do to help make her more comfortable. Assistance with dressing. She might be at risk for bladder infections because she's not able to get to the bathroom by herself. Or she might be incontinent and we have to keep her cleaned and changed. All right, after the assessment is made and the nursing diagnoses are together, then we have to plan. What are we going to do with these diagnoses? What are we going to do to make these problems better or tolerable? Planning involves setting priorities and goals. The priorities relate to what's most important for the person. So, at risk for falls, the goal would be to not fall. Okay, so we set the goal and now create nursing interventions. The non-skid shoes, make sure she has her walker handy when she gets up and about. Encourage her to use her call light. Maybe she has to have a gait belt. She has to have assistance to be gotten out of bed. So whatever the interventions are, we'll add those to the care plan and everyone will follow those interventions. The Interdisciplinary Care Planning Conference is held to develop a comprehensive care plan because every department is going to create their own plan. So, activities director, she'll go interview Taylor. What do you like to do? What did you like to do? Well, I used to like to quilt, but my hands won't let me do that anymore. What else did you like to do? I like to garden. Okay, let's see what we can do about that. So maybe they have a quilting session where you don't sew quilts, you put them together with cardboard, paper, and glue. Or maybe you can't bend over to garden. So they'll build you up a garden in the courtyard so you can reach those things from your wheelchair or your chair. So they do a lot of different things, but every department has a way to create their part of the care plan. Nursing department uses the nursing process. Okay, so the Interdisciplinary Care Planning Conference is held to develop the comprehensive care plan from all these departments. Okay.
As a SRNA, do they assist in the planning and the goal setting, or is that just strictly for the nursing and above?
No, nursing assistants are crucial because you have one-on-one contact with that person every day. So any input that the nursing assistant can give is vital. Maybe they'll tell you, you know, when I was younger, I really used to love to make jewelry, but they didn't tell anybody else that. And you're with them every day. You know, they send me those green beans on my tray 2 or 3 times a week, and I hate green beans, but I don't want to hurt anybody's feelings by saying something. Pass that on, because the nursing assistant are the eyes and ears.
Parkinson's patients often have hallucinations.
Mm-hmm.
And what if they, where does that fall in? Is that for the doctors? Is that, certainly the care assistant ought to know about that.
Yes.
Yes.
Anytime they have anything like maybe hallucinations, sundowning. Sundowning is when their behavior changes in the evening from the day. All of that needs to be on the care plan, so the nursing assistant can anticipate if that should happen. Because if you don't know to expect it and they suddenly start talking out of their head, the first thing you're going to think is that they're physically ill. Oh my gosh, they're dehydrated, they've got ear infection, something's major wrong. But it's not. It's typical of that diagnosis. And they'll care plan what we're going to do when that happens. So maybe this person can be redirected. Maybe another person, you just have to go along with it until it passes. So it just depends on each person. So, and they do have medicine that can be given to help reduce the incidences of hallucinations and behaviors. So it just depends on each individual person. But that's a good question, because those kinds of things are on the care plan. Does that person have a tendency to strike out at others? What do you do if this person is in a bad mood? And anything that nursing assistants can contribute that changes that person's behavior is a big help. Because a lot of times they know when nobody else does. Okay, the comprehensive care plan includes nursing diagnoses and goals, the problems and actions to take to help solve those problems, and the person's strengths. Always add that. So maybe she does have tremors and she spills her food, but she can hold a 2-handled cup without spilling it. That needs to be added. She's able to do that by herself. What are her strengths? Add that to the care plan and encourage the patient to continue with those strengths. The care area assessments are guidelines used to develop the person's care plan. The minimum data set gives triggers. So if you pull up the MDS, it's going to say this person has a problem getting to the bathroom on time. So what are we going to do about it? Or this person isn't able to walk by themselves. So it has the care plan with the problems and what to do about it. The care plan forms vary. They might be in a chart, a separate notebook for everybody, a Cardex, or even on the computer. But you'll learn that in your orientation to whichever facility you go.
Are they still using Cardexes?
You'll find them occasionally in some of the older facilities. There are still facilities that do paper documentation. Not many, but they are there, here and there. Okay, the 4th step in the nursing process, implementation. Care is given in this step. This is when you put the plan into action. Report the care you've given and your observations to the nurse, especially if it's a new plan, to let the nurse know how that went. The nurse will use the assignment sheet to communicate delegated measures and tasks to you. If your assignment is not clear, talk to the nurse, check the care plan or the Cardex. And they do have care plans on the computer for the facilities that utilize computer documentation. So you can always go to that. The assignment sheet is used to communicate tasks. It tells you about every person's care, what measurements and tasks need to be done. So maybe Ms. Jones gets her vital signs checked every Tuesday and Thursday. Because she's a cardiac patient, unless she's in distress, that's routine. Also, your assignment sheet will tell you what nursing unit tasks to do. Most of the time, everybody has a chore. Maybe your chore today is to straighten the shower room, make sure everybody's toiletries are out of there. Maybe it's to make sure that the dirty utility room is clean. There's not any dirty linen on the floor, trash has been taken out. It might be to make sure all the vital signs equipment has been cleaned. So everybody has unit tasks to do as well. Use your assignment sheet to organize your work and set your priorities. What needs to be done first? Maybe you pick up your assignment sheet and it says Ms. Jones needs to be ready to go out to a doctor's appointment by 8 o'clock. Hurry up and get her breakfast. You've got to get her dressed. She's got to be on that Wheels bus by 7:30. So it'll tell you what's going on. It might even tell you, or you might be able to decide what you're going to do while your patients are at therapy or during meal times. That's a good time to get some paperwork done. You can also help straighten rooms, make any beds that haven't been made yet. With which task will you need help? Check off your tasks as you complete them. The last step in the nursing process is evaluation. The evaluation step involves measuring if the goals in the planning step were met. Changes in the nursing diagnosis, goals, and care plan may result. Maybe it didn't work, so let's do something different. The nursing process never ends. You're constantly going to have changes in your patients. Your role, the nurse uses your observations for nursing diagnosis, planning, and evaluation. You may help develop the care plan. In the implementation step, you perform nursing actions and measures that are in the care plan. The resident has a right to take part in their care planning. The person might refuse actions suggested by the health team, and they have a right to do that. So maybe they don't want to get up at 6 o'clock in the morning. Let's make them happy. Let them get up at 8. So if they don't agree with the plan of care, then everybody works together to make it favorable.